Okay, it's 10:15, so we'll get started. Good morning, everyone. Welcome to APSA Breakout Session number 9, which is a session brought to you by the APSA Fetal Committee and is entitled Artificial Placenta, Fantasy or Reality. My name is Sean Kunisaki, and I'm the director of the fetal program at the Johns Hopkins Children's Center in Baltimore. It is really my distinct honor to moderate this panel presentation. All of the credit actually for the session should go to the speakers, as well as the chair of the APSA Fetal Committee, who is Dr. Daryl Cass from the Cleveland Clinic, who unfortunately could not be here today as his son is graduating from law school. But Daryl certainly sends his regards. Next slide, please, or I guess I can do it. So today we really have an illustrious panel of speakers. The first is Dr. Barbara Warner, who is a neonatologist and the F. Sessions Cole Professor of Newborn Medicine at the WashU School of Medicine in St. Louis. Many of you probably already know and are familiar with her other esteemed half. That's Dr. Brad Warner. And she's going to set the background by discussing really the current status of infants born at the extremes of prematurity, really with a special emphasis on low gestational age, morbidity, as well as mortality. The second and third presentations will be from one of my good friends and former partners, Dr. George Mialishka, who's professor of surgery at the University of Michigan. George will give a brief history of the artificial placenta, and then really will give a lot more specifics on the extraordinary experimental work that he has done in this field. I think George is rightly credited for really renewing interest in this technology as really a natural extension of the work done at Michigan in ECMO by Bob Bartlett. And then finally, last but certainly not least, we'll hear from Dr. Alan Flake, who is professor of surgery at Children's Hospital Philadelphia. Alan will discuss his exciting work with an alternative device platform for the artificial womb known as Extend, which stands for Extrauterine Environment for Newborn Development. There are polling questions which during the talk, so please have your Whova apps ready to answer these questions. Also save questions from your talk for the end. There will be a panel discussion that will follow. My hope is to keep this as a friendly debate among surgeons with certainly little or no bloodshed. And I sure hope that most of us really will be interested in learning how implementation of this type of technology really can happen, as we certainly think about this as a fairly radical paradigm shift in our thinking about how to best manage extreme prematurity. So without further ado, let's get things started with Dr. Warner. Thank you.
Thanks for having me. I feel so lucky to know so many of you already in the audience. So this idea of this limit of viability has really been an issue as long as neonatology has been around. And we have made some improvements since when we were displaying babies in Coney Island in the 30s and 40s that could survive in an incubator to where we are today. And my goal really today is to focus on an objective iteration of the literature that can provide us with an update as to where that limit of viability is. So over the last couple of decades, we have seen improvement in survival, particularly in the children that are at the limit of viability during that time period, which was around 23 weeks. And I want to take a moment to call attention to the denominator because they do vary in these type of studies. So if you use a denominator of all live births versus if you use a denominator of live births that have received active resuscitation versus if you use a denominator of NICU admissions, you're going to have very different survival figures. So it's important to pay attention to what that denominator was. Over the years, there's been many advances that have pushed down that threshold of viability. And while I certainly cannot be old enough to remember those human studies of surfactant in the 80s, I'm sure that my colleague, Dr. Flake, and my husband, Dr. Warner, accurately remember those days. But there have been advances both in terms of decreasing mortality and pushing down that limit of viability, as well as in morbidities. There have been a number of both surgical as well as medical advances that are not included on here. Certainly the intervention of placing of drains as an option for babies with NEC and SIP has altered the care and outcomes of those babies. The increasing small size of catheters all have improved those numbers and decreased that gestational age. As that gestational age decreases, though, even though there's been a number of different advances to try to decrease the morbidity continues to follow those early gestational age infants, as we'll see. So first polling question. What is the national survival figure for infants born at 22 weeks gestation? 22 weeks with active intervention. And will this magically show up somewhere?
It's in the Hoover app here.
I can just tell you the answer.
Sure.
So the answer is 30% survival. Okay. So that may be a surprise for some people, may not be a surprise for other people, but 30% is the current active intervention survival rate. So what does the literature actually say about survival at that early gestational age? There's still a lot of controversy around resuscitation at 22 weeks. I'm going to highlight this article because it's the most current, published at the end of 2022. It encompasses a time period from 2013 to 2018, so fairly recent in terms of the type of care those infants received. It's 19 academic centers, many of which you were probably part of through the NICHD. And most importantly, it reports the figures for survival on the infants that received active intervention as well as survival without active intervention. And active intervention is defined by if you were intubated, if you received a dose of surfactant, if you received respiratory support, if you had chest compressions, and if you received TPN during your hospitalization. That was active intervention. So these are their survival figures. Again, using the denominator of all live births, you can see that we can get kids out of the delivery room. It's better at 23 weeks than at that 22 weeks. And if you look at discharge to 1 year, you see that there is a gestational grade increase, about 50% for 23 weeks, 70 at 24, and 80 at 25. The 22-week survival at all live births as a denominator is about 10%, and that's a number that's commonly quoted. If now you pull out infants that are actively treated, you can see that we are much better at getting almost everybody or a significant component of those babies out of the delivery room. But if you look at survival to discharge or survival to 1 year, because not all the babies are out of the hospital by a year, then you're looking at numbers that are 30% for 22 weeks, 55% at 23 weeks. Those numbers are very different compared to the ability to get them out of the delivery room. At 24 and 25 weeks, that discrepancy is a little bit less. And then when you look at the survival figure using actively treated versus total live births, the biggest discrepancy is in those 22 weeks infants. Now, there are a number of different studies that have reported single site survival. And recently, the University of Iowa reported 70% survival to 1 year. That's the highest number that I could find. There are a few other reports. When you look at other multi-centered studies, so the Canadian network reported a survival rate closer to what we see in the NICHD network of around 30% for actively treated. I unfortunately did not include the Japanese network, which actually for many years has reported much higher survival than other sites and in the 50 to 70% survival rate at 22 weeks gestation. So beyond just survival, there's also morbidities. Interestingly, for infants with NEC, either medical or surgical NEC, there's not that much of a difference over these early gestational ages. You see a decrease in intracranial hemorrhage for infants that have reached 24 weeks, severe intracranial hemorrhage. The number of tracheostomies are not that high. Now that comes with concomitant increase in the withdrawal or limitation of care as the gestational age lowers. So 35% ended up with withdrawal or limitation in their care. Probably the thing parents most want to know about is neurodevelopmental outcomes if my babies survive. And the two colors I'll have you focus on are the dark black, which is the mortality. So these are the numbers that we just saw. There's 70% mortality or 30% survival. How you say it when you talk with families is certainly very important, as well as the lighter tan color, which is survival with no or mild neurodevelopmental impairment. And while there is a gradual increase in infants that survive with no or mild neurodevelopmental impairment across gestational ages, the biggest increase doesn't occur until 25 weeks when you reach close to 40% with a concomitant decrease in infants that survive with severe neurodevelopmental impairment. So the risk of moderate to severe neurodevelopmental impairment does decrease, I should say, across gestational ages. And it continues to be a problem for this population. So just a moment, because in today's day and age, maybe more important than what we say is what the media says. And just to take a quick look at what parents who are in this situation find when they go onto Google and onto Facebook or other types of social media. So we've all seen the news feeds of the miracle baby who has survived, born the smallest baby, the earliest gestational age baby. There's also an parent advocacy group called 22 Matters that will provide geographic locations of the hospitals that resuscitate at 22 weeks. And I in no way want to diminish the importance of parent advocacy or hope for parents. But what is sometimes concerning is that the goal is really a shared model of decision-making. And sometimes, based on what's on social media, I'm sure we've all experienced, sometimes that feels a little bit unbalanced. So in summary, parents are increasingly asking for interventions at the limit of viability. The 1-year survival we already reviewed, it's higher at single centers. There's still a lot of variation in terms of the centers, the percentage of centers that intervene at 22 weeks and don't intervene at 22 weeks. There's a high risk of associated morbidity, and the risk for moderate to severe neurodevelopmental impairment does improve. It's slower than the improvement in the rate of survival between 22 and 24 weeks. And with that, I will hand over the next person.
Thank you very much, Dr. Warner, for setting the stage. I'm going to spend just a few minutes talking about the history of the artificial placenta, and I have no disclosures. With the advent of the heart-lung machine in 1953 and open heart surgery, researchers were already beginning to think about extracorporeal support for extremely premature infants. And in part because that's the natural physiology, and in part, we haven't had all the advancements that Dr. Warner talked about. So believe it or not, as early as 1958, there was an experience of perfusion of pre-viable human fetuses. These were 200 to 375 gram pre-viable fetuses, and they were perfused for 5 to 9 hours. A number of years later, when the Beatles graced the cover of Life magazine, tucked in the magazine was this obscure article about the artificial placenta or the artificial womb, and this was Callahan in 1964, which perfused a premature lamb for an hour. Several years later, this is Zapol and Kolabo, who is responsible for a lot of oxygenator technology. They presented in Science support of premature lambs for up to 2 days using a silicone membrane oxygenator. Now, over the ensuing decade, again, as Dr. Warner alluded to, there were concomitant advances in neonatal care, surfactants, steroids, the beginning of more sophisticated ventilatory strategies, and so the more premature babies were doing well. At the same time, there was a growth of neonatal and pediatric ECMO, and there was success of extracorporeal support for term and near-term infants. During this time period, there still were a number of investigators working on the artificial placenta, but during this time, the advancements were episodic. But technology was continuing to advance, particularly in terms of low-resistance oxygenators, cannula development, and we were learning more about fetal physiology. So in the last 2 decades, there has been accelerated progress. At the University of Michigan, you'll hear about in a moment our work developing what we call the artificial placenta, a VVECLS platform. And later in this session, you'll hear from Dr. Flake describing the AVECLS model or his Extend system. And over the last decade, there's been now a resurgence in interest both from clinicians and bioengineers in multiple laboratories around the world, refining components for use in the artificial placenta. And certainly you'll hear that we are definitely progressing towards clinical translation. Now I'm going to pivot and share in 10 minutes nearly 2 decades of work at Michigan. This work was supported by the NIH, and my disclosures, I'm happy to disclose and grateful that I had Mike Harrison, father of fetal surgery, as my mentor in the early part of my career. And in the latter part of my career at Michigan, Dr. Bartlett, the father of ECMO. And without Dr. Bartlett and his laboratory that he set up over 40 years, none of this work would have been possible. One piece of advice that Dr. Bartlett gave me was to pick a problem you can spend the rest of your life solving, and I think this fits the bill. So we've already heard, and I will not reiterate the unsolved clinical problem of prematurity, but just point out that growth development should occur in a low oxygen fetal environment with fetal circulation and no ventilation. And the many severe complications of prematurity that we all see, chronic lung disease, neurodevelopmental problems, NEC, ROP, and sepsis, are in a way iatrogenic in our efforts to treat these babies with our current conventional life-saving therapies. And I would argue, and I think Dr. Flake will agree, that LGANs are fetuses and should be treated as such. So a radical paradigm change is to develop an artificial placenta to support these infants. The key principles are maintaining fetal circulation, providing a low oxygen environment, no mechanical ventilation, fluid-filled lungs, and the platform can be either a VV or AVECLS model. And this one slide represents nearly 2 decades of evolution in our laboratory developing this technology. On the top left, you see a pumpless transumbilical AV-ECLS model. So this is where we started. In our hands, we had limited support. We had physiologic flows and physiologic gas exchange, but we had issues with persistent umbilical artery spasm, which completely shut down the system. We then moved to a pump-driven system, and we had longer success, but we still had issues with umbilical artery spasm. We then moved to the bottom left to a VV-ECLS approach with the animal submerged. And in this model, which is mostly what I'll talk about henceforth, we had infusion through the umbilical vein, but the drainage was the jugular cannula. And we also began thinking about clinical translation early in our work, and we felt that the submersion method, we had issues with infection, and we also felt that for clinical translation, the model on the bottom right, where we have an endotracheal tube and the lungs are filled with perfluorocarbon, that is a model where you have caregiver access, and we could use the platform of ECMO to translate the artificial placenta. So our early work compared the artificial placenta to mechanical ventilation controls, and you can see we borrowed an oscillator, don't tell anyone, from somewhere, and we had our the head of neonatology, Dr. Barks. He treated these premature lambs as he would a premature infant versus the VV-ECLS artificial placenta. And the premature lambs survived for 1 week versus only a few hours with mechanical ventilation controls. And so in our early work, we really focused on achieving longer-term support, hemodynamic support, and fetal gas exchange while maintaining fetal circulation. We then spent the next decade looking at organ development on artificial placenta support. And our goal was to demonstrate that we had ongoing organ development and protection during artificial placenta support, because the whole point would be to place the animal on this support for a period of time, probably 3 to 4 weeks. And during that time, we wanted to ensure that the organs are protected, but that they also show indices of organ development. We focused particularly on lung development, and our data from multiple studies indicated that the functional, morphological, and molecular data showed that development continues and lungs are protected from injury during artificial placenta support. Another area of focus was cerebral oxygenation, perfusion, and protection during AP support. And using multiple different studies on the left, you can see these are our perfusion studies using NIRS technology, carotid flow probes, as well as postmortem MRI. We demonstrated that cerebral oxygenation and blood flow in premature lambs are maintained during AP support, and there was normal cortical folding with no white matter injury or bleeding. And this is an example of an animal on the AP. You can see the jugular drainage catheter here. This is the inflow. The animal, in this case, the endotracheal tube was capped, which interestingly on some histologic analysis demonstrated that we had accelerated lung growth, like a tracheal occlusion, but currently we just leave it to a meniscus and they're basically doing fetal breathing movements. And this is a short video showing an animal whose lungs have been suctioned and recruited. and now is just breathing supplemental oxygen. The cannula is still in. There's no sweep on this animal. And this slide demonstrates what we believe is an absolute breakthrough for clinical translation. We're all familiar with the fact that premature infants, as Dr. Warner pointed out, are at very high risk for intracranial hemorrhage and systemic heparinization, which currently is the standard for any extracorporeal circuit. The risk would be prohibitively high for these premature infants. And this work and this approach really represents over a decade of work by Dr. Bartlett and Dr. Meyerhoff, who's a chemist, developing the NOSIS system, the nitric oxide surface anticoagulation. And this was just recently published a few weeks ago in Pediatric Research. And the idea is that this surface coating that we apply to the circuit, it elutes nitric oxide at the same flux units as endothelial cells and prevents clotting at the surface. Because current oxygenator technology is such that you cannot coat an oxygenator or you wouldn't have gas exchange, we developed an NO generator, and we basically add nitric oxide to the sweep gas of the oxygenator. And we demonstrated, compared to controls, 5 premature lambs survived for 1 week with no systemic anticoagulation. There was no bleeding or thrombosis, and this truthfully is a representative image of what the circuit and oxygenator looked like on all the animals. And during this time, we also maintained normal fetal gas exchange, hemodynamic stability, and maintenance of fetal circulation. So we think this technology is essential for the artificial placenta, but also likely will be used in all of ECMO and other forms of extracorporeal support. So even preemie ECMO, when many of you in the audience put a 30 or 31 week infant on ECMO, if you had a coated surface, that elevated risk of IVH that we see in those infants should go down. The last area our laboratory is working on is miniaturization. The fetal lamb model that we have used is about 115 to 118 day model, term being 145 days. And it turns out that that animal, the lung development is equivalent to a 24-week human infant, but they're much larger. They're about 2.5 kilograms. So we've done a number of different studies in 90 to 100 day lambs, which still you can see are 1.5 kilograms. So we're working on a different species, if you will, a mini sheep model, trying to get that animal down under a kilogram. And we're also developing a Yucatan pig model to test the feasibility of a miniaturized system. So in terms of clinical translation, there's still a number of hurdles. Of course, technical and regulatory issues, understanding informed consent in this scenario. For the AV ECLS model, I'll let Dr. Flake discuss that, but there needs to be prenatal risk stratification and consideration of maternal risks. For the VV ECLS model, which I've described, I'll show you a little data on postnatal risk stratification. And of course, we could spend an hour on the many ethical considerations which still need to be addressed. In terms of prenatal risk stratification, the main stratification is based on gestational age, as Dr. Warner pointed out, but there are a few other factors: birth weight, infant sex, singleton birth, and antenatal steroids, which influence the the outcomes. And this table that I made here is based on the NICHD extremely preterm birth outcomes tool. And I've highlighted the 24 weekers where I see before birth, this is an area where, again, as was described, overall survival is 70%. For females, 58 to 65% have mild or no impairment. And for males, 42 to 65% have mild or no impairment. So to me, this is an area where the neonatologists have made substantial progress. And I think we have to be careful about applying the technology to these patients. And interestingly, when I was looking at prognosticating outcomes for premature infants, it was the neonatologists who pointed out to me that all of death does not occur on the first day of life. And in fact, it occurs, this is based on data from the NICHD, it occurs over a long time period. So the question for our group was, on day one, even in fact within 4 hours, could you build a predictive model that would predict death that may occur days later? And so this is not yet published, but this is our retrospective data, institutional data of Elgans at the University of Michigan. And you can see receiver operator characteristic curves at 4 hours for SNAPI2, SNAP2, and CRIB associated with mortality by discharge. And in our institution, SNAPI2 at 4 hours of life had an AUC of 0.8 and was the best predictor of mortality in a retrospective series. We're currently several years into an ongoing prospective study, an interim analysis. We didn't have a large enough sample size yet, but revealed that all 3 models demonstrated higher averages for infants who did not survive to discharge. We've added additional variables, including markers of long-term morbidity into the model, and we're hoping that we'll have a robust model to be able to select that premature infant within 4 hours who has at least an 80% chance of death during the hospital course. So the polling question 2, when miniaturizing the VV-ECLS artificial placenta for clinical application, the flow rate will be determined by... Am I supposed to give the answer, Sean?
So far, there have been only, well, it looks like 6 responses. Looks like most people chose A.
Okay, so the answer is actually D, the size of the internal jugular catheter, because it's very similar to ECMO principles that you can have a small cannula for inflow, but your flow rate is determined by your venous return. And to wrap up about clinical translation, as you'll hear, clinical application differs between the artificial placenta and the Extend system. There are different maternal and fetal considerations and risk-benefit profiles. In the artificial placenta, as I mentioned, early application would be using a prognostic indicator and putting those patients on early. The pros of that approach would be good risk stratification applicable to most Elgans. The cons would be that there would be at least some lung injury from initial trial of ventilation. We know that we may not capture all the infants in the first 4 hours of life. So a week or 2 later, if a premature baby is failing maximal medical treatment, there could be another approach of late application of the artificial placenta, with the cons being there may be moderate lung injury at that time and fetal circulation may not be initiated, but it would still be a rescue therapy, much like the way we use ECMO today. And I personally believe eventual clinical translation will be a hybrid approach utilizing both technologies. I want to thank and acknowledge, as I did, Dr. Bartlett, Dr. Rojas, who runs our lab, literally hundreds of undergraduate students, dozens of technicians, but this is just a picture of my postdoctoral fellows who over the years have worked on this project, and as all the faculty know in this room, they did all the work, and they really were amazing. Thank you very much.
That's a great prelude to my talk by both Barb and George. So we do call this extend. We don't call it an artificial womb. It has test tube baby connotations, etc. And so we prefer this term as an extending gestation. I have a lot of disclosures. That's why this is no longer CME credited. So if you expect CME credit out of this session, you won't get it. All right. First time it's ever happened to me at a meeting, by the way, that they withdrew the CME credit for my talk. Okay, so we consider extend not just a technology for the extreme premature, but really a platform technology for support of the newborn during extreme premature or other difficult transitions from the maternal womb to the outside world. And if you think about this, which is the fun part, there are all kinds of potential applications for this technology that extend beyond just the extreme premature infant. I don't have time to talk about them today. We already have a polling question. I'll let you guys read that, give your answers. I'm trying to remember the correct answers here.
I know the right answer, Alan.
Oh, I've got it. Yeah, I've got them up there. All right. So the correct answer, or the wrong answers, are blood flow circuit containing centrifugal pump. It's a pumpless AV circuit. And then we're not trying to support 100% umbilical venous oxygen saturations because the fetus normally has about 60 to 70% umbilical venous saturations. And so it's A and C. All right. Okay, so the essential components of extend break down to really having a sterile fluid environment, which is achieved by an enclosed system that has continuous fluid exchange, fresh fluid in, waste fluid out. It's really enabled by the low resistance oxygenators, the hollow fiber plate oxygenator technology that we use in ECMO, which allowed really in the past 15 to 20 years the achievement of a very low resistance, low volume circuit that's analogous to the placental circulation. And finally, the ability to use the umbilical arteries and vein as a conduit to the circuit successfully is what really enables this to be truly physiologic for the fetus. So what's the role of these various components in preventing the morbidities of extreme prematurity? And, you know, we talk about mortality all the time. Mortality is obviously one goal, but the real goal is to have babies that survive without morbidities. And that's what's often missing in these analyses of improved survival, incrementally improved survival in the extreme premature infant. So the sterile fluid environment is critical for normal lung development. And that includes not only the fluid component of it, but also the normal airway pressures that are produced by the resistance at the larynx and fetal breathing movements. So that's the obvious benefit of fluid. Even a little gas ventilation arrests the lung in the canalicular stage of development. And so you want to avoid any gas ventilation if you really want to prevent BPD and chronic lung morbidity. It also provides multiple other benefits. Stable temperature environment protects the fetus from outside pathogens, obviously, prevents mechanical injury, etc. The combination of the pumpless AV circuit and the umbilical venous conduit really mimics the placental circulation. It maintains the low cardiovascular workload that is required for normal cardiac development during gestation. It does allow autoregulation of circuit flow if you have a capability of that at an appropriate gestational age, and I'll explain that. But that's actually mediated through the UV, DV, umbilical vein, and ductus venosus by the fetus. And it allows high physiologic flow at very physiologic oxygen saturation. So you have low oxygen saturations, therefore to have normal oxygen delivery, you need very high flows. And the umbilical vessels are really the only conduits in a pumpless system that allow you to do that. There are other benefits. I was thinking yesterday with the dilemma about narcotics in babies and the potential effect on neurologic development. We require no sedation in our system. The fetus basically doesn't have any painful impacts. So if you combine all of these things, you really do address almost every acute and associated chronic morbidity of prematurity, theoretically. So rather than have a debate here, because I really don't think they're comparable, directly comparable technologies, and I do think they're non-competitive, as George mentioned. I think there's a role for both. But you really want to answer with each one, does it maintain normal fetal physiology? Does it support normal organ development and growth of the fetus? Is there preclinical evidence to support clinical application, primarily safety data? And is clinical application feasible? And I'm going to go through a whole bunch of things very quickly here to try to support those points. So we published our original work in a 105 to 113 day gestation fetal lamb model. This is an appropriate model for lung development, as George mentioned, but there are some important differences between that gestational age lamb and a human 23 to 25 week fetus. But what you can say about the evidence from this study, as well as multiple studies that have been published since that time in our system, is that these parameters are normal. And I have an asterisk there because obviously they're normal within the confines of our ability to detect abnormality. But the fetal circulation is absolutely maintained. Cardiovascular parameters are normal. Cardiac function is normal. Oxygen delivery, somatic growth, metabolism are normal. And extensive assessment of lung development, brain development, and gut development focused on those three organs has been normal. So I can put check marks in front of these first three categories, at least in the 105 to 113 day gestation lamb model. But there are problems with that model, as we recognize and as pointed out to us by the FDA. The biggest issues is it a surrogate for neurologic development in the human? And the answer to that is it's clearly not a good model for IVH, and that's because the lamb brain matures earlier than the human brain relative to the lung development. So the maturation of the germinal matrix and the medulation, or the process of myelinization of the brain, really occur more like between 90 and 105 days gestation in the lamb. And that's the best evidence we can find for that in the relevant literature. So at the FDA's request, and also out of obvious desire to demonstrate a more relevant model, we went to the 90-day lamb model. It's not size equivalent. There's a lot of variation in the size of lambs at 90 days, but we do have lambs that are in the 600 gram range in our study, and they go up to about a kilogram initial weight. And the lung is in a very early stage of gestation. I think in general, the lambs are extremely premature, as you can see, or immature, as you can see by the lamb in this video. They're somewhat gelatinous. I think they're more like a 17 to 19 week human fetus in most respects. But in terms of brain development, they are more analogous. So we did a study in this model, running lambs for 14 to 21 days. This required some preliminary work to develop a methodology that kept them stable for that period of time. And the biggest thing was that lambs at this age don't have the ability to autoregulate blood flow. And so if you just put them on a pumpless AV circuit, you'll see an increase in their cardiac output progressively, and they'll ultimately end up in high output cardiac failure. And so we learned to use a resistor in the circuit basically, and to follow cardiac output as our surrogate for how much resistance is required to maintain normal cardiovascular hemodynamics. And if you maintain a fairly normal cardiac output with circuit resistance, then you maintain a normal shunt fraction in that circuit, and you don't develop heart failure. So we took a little working out to figure that out, but once we did, we can actually maintain these lambs in very stable condition, physiologic condition, for 14 to 21 days. Most of the 14 days were for neurologic analysis to look for IVH. There were deliberately, the studies were ended at that time point. So this is just the cardiovascular data. The other big question is whether the smaller cardiovascular system, less mature cardiovascular system, could withstand the stress of the pumpless AV circuit. And if you think about it, if you can match the specifications of the human placenta and the volume of the placental circulation, the fetal heart should be just fine and tolerate that well. It does for 9 months in utero. So we were pleased to see, and this is an additional group, and as an IUGR group, we serendipitously had 3 animals that it was a very hot summer, and we thought they were, the gestational timing was wrong on them, but we double checked that a couple of times with the breeder. They were apparently 105 to 115 day animals, and they were 600 to 750 grams. And we maintain those animals in the circuit. They're a separate group here. But you can see that regardless of the size of the animals, and these range from 650 or so to a kilogram in size, the hemodynamic parameters, oxygenation parameters are very consistent with the older animal group, which is overlaid on this graph. I like this, where you actually put the 90 to 105 day and the 105 to 125 day data in continuity, and you can see there's continuous growth of the cardiac parameters, which suggests at least that you have normal cardiac development. And by all echocardiographic criteria, and we've had Jack Rychek analyze this carefully, he believes that cardiac function and development are normal in the animals. Somatic growth is appropriate and proportionate in these animals. And then the most important thing, and this was assessed independently because it's an FDA-requested study by an independent veterinary radiology consultant. We did MRIs on all the animals at the end of their runs, and we analyzed to that for maturational indices and evidence of ischemia or IVH, and there was no evidence of any intraventricular hemorrhage or ischemic injury, and the maturation parameters were normal relative to age-matched controls. The same with histology, did extensive histologic analysis, did inflammatory markers and markers that are activated by hypoxia, and those are all normal relative to age-matched controls, suggesting that we had normal brain development. And also there was no evidence, again, of IVH or ischemic injury in the animals. So evidence for safety, the system is robust, stable. We've now applied it to over 300 animals. In general, a single trained fellow or technician can care for 3 animals overnight, etc. It's honestly a very stable system. We've not observed acute irreversible events that threaten survival or neurologic injury, things like irreversible cord spasm, circuit thrombosis, cannula erosion, dislodgement, major hemorrhage, including IVH or organ failure. And so if you do have a reduction in circuit flow, it's usually you have warning and you can respond to it. And it's important to realize the only connection to the fetus is the cord cannula. So we haven't burned any bridges for resuscitation of a premature infant. And if we do have reduction of flow or any threat to the well-being of the fetus at any time, we can rapidly deliver them and apply standard of care resuscitation of the premature infant. So that's ultimately for the FDA to decide. Where do we stand with FDA regulatory approval? We were fortunate to get in the early feasibility study, and that was the predecessor to the breakthrough status designation that the FDA has done. And the important aspect of that is it allows you to interact repeatedly with the same people at the FDA, ask questions, work out answers together, and hopefully by the time you submit an IDE application, you'll have addressed most of the concerns that the FDA has. And so that's what we're doing, and the FDA asked us to do multiple bridging studies, and these were really to see, is this applicable to the human premature fetus? And bridging studies are bridging the differences between the sheep system and what we see as the extreme premature human. And these include cardiac output, blood flow differences. We've designed a smaller oxygenator designed for human blood flows, and we've tested that in a parallel limb of the sheep system at human blood flows for appropriate duration, looked at gas exchange, looked at blood health, looked at thrombosis, all those things, and that oxygenator performs much better than the actual McKay oxygenators, in fact. Again, the size of the lamb, we're working the 90-day model. It's not exactly size equivalent, but it's approaching size equivalence, and we do have some animals that are size equivalent in the study. On top of that, we're working in the near-term pig model, which is a great model for testing the transition from the placental to the human device, because the porcine umbilical cord is identical to the human in most respects, and they're size equivalent near term. So they're not a good developmental model for the device, but they're a very good model to test your ability to apply this clinically. And this is just a picture of the human device, or the human prototype device. We're testing this, doing engineering validation testing, toxicology studies, all of those things with the device. And this is a near-term pig that's in the human pod in the device. Develop cannulation systems that are designed for MFMs to use, actually. Pediatric surgeons shouldn't be doing this procedure. And I can do this, take them from placental support to physiologic flow in about 1:15 to 1:30 seconds. That's well within the safety window. If you do primate studies of cord occlusion, you have 10 minutes or so before you have irreversible neurologic injury. And so that's a very reasonable safety margin. So we're working with the pig model extensively now to try to practice and perform all of the aspects of the transition. So I think there is preclinical evidence to support clinical application, at least as much as we can obtain in appropriate, relevant lamb and porcine models. And the only way we'll know if it's applicable to human fetuses is to do a trial in human fetuses. What's it take to accomplish Extend? In the left-hand picture is an early picture of the Extend system. You see Emily there in the middle, who did the first study of the Extend system, and Marcus Davey, who's my long-term collaborator and co-inventor on the technology. He really designed most of the systems that we use in the lab, and now the human. I have to acknowledge CHOP, because I don't think I could have done this anywhere but CHOP. There's been a massive financial investment in this project. You can imagine the expense of doing this, and CHOP has pretty much shouldered the majority of that until recently. So thanks for your attention. Happy to field questions with the panel.
Thank you, Alan, George, and Barbara. 3 really extraordinary talks. I've watched this technology evolve over the last 10 years now, and I'm always really in awe about this. And there's so much to unpack. Unfortunately, we only have about 5 or 10 minutes, but I did want to provide an opportunity for people to ask specific questions about this.
Vikas Gupta from Dallas. Thank you so much. This is an elite panel, and it's great to reconnect with all of you. I had a question about the history of the development of pumpless ECMO. As far as I know, it's gone through so many different iterations, and there's been adult studies for at least the last 20 to 30 years about lung assist devices, the Nova Lung, et cetera. In y'all's development of these systems, did you collaborate with those adult investigators? Was it developed independently? What did that process look like as y'all got to pumpless ECMO?
We just tried it. I think the difference that isn't generally appreciated between our AV pumpless circuit and ECMO in general is that it's a very low volume circuit with very high flows. And so, and I think that's a little different on a scaled basis than it is in adult lung assist devices. And so from the beginning, the AV pumpless circuit, even when we had it hooked into the carotid and jugular system, performed very well in terms of hemodynamic and metabolic support. We've downsized that. We have an oxygenator with about 1/3 the priming volume of the pediatric McKay, and a smaller circuit as well. And with that smaller system. Again, the blood flows are very high for the volume of the circuit, and it's been pretty non-problematic from our perspective.
Hi, I'm Sarah Taylor. I'm a resident at Cincinnati Children's. I was just curious, how far out has the longest animal been taken? One of the graphs earlier in the slides showed how mortality isn't highest right at the beginning. It kind of comes later as the consequences of prematurity develop. So how far out have animals been taken? Have we looked at resuming feeds? Some of those later processes that happen in the NICU and lead to morbidity.
Surgery.
Yeah. So most of the data that I showed, we specifically, in terms of looking at organ development, et cetera, we typically did 1 week, but we've had other animals that we've gone close to 3 weeks. And we had early on one animal that we kept alive that went to the farm, who had a short course on the artificial placenta. But, as Alan pointed out, this is very labor intensive work. So most of our experiments, we had defined intervals.
And so we've gone 28, we actually gone 29 days on the system in one animal. We've sort of limited that for a few reasons. The FDA, anything over 30 days considers an indwelling device, and the regulatory hurdles are much higher than that. For that, I think clinically you could potentially extend the time period beyond 4 weeks if it was clinically appropriate. In terms of surviving these animals, you really need a lamb intensive care unit because lambs aren't built to be on the ventilator. So if they spend any time on the ventilator, they're really very hard to get off of the ventilator. We have had survivors. We've had 4 long-term survivors earlier in our experience when we actually tried to get some survivors. And 2 of them died within the first month. One was from a pyelonephritis that was unrecognized. The other was from an open PDA that we didn't recognize. Both were good in other respects. And then 2 of them lived long term. One of them went to the farm and died in a barbed wire accident. Emily was very close to this animal. It was really a shame, but it'd be about a year of age. By all appearances, that lamb was normal. We had another one that we actually did neurocognitive testing on, executive recall, all that stuff. There's actually a way to test that in lambs, and it was smarter than the average lamb, and it lived to be over 6 months. We ultimately sacrificed it, did MRIs of the brain, et cetera. And it was normal as far as we could tell in all respects. So that's the long-term data that we have, but that has not been a focus of our research.
Morning, Hiroshi, Sacramento. Thanks so much for giving that great series of talks. I wanted to ask the panel, have your opinions on the sort of potential downstream uses of this technology electively. And people have talked about being able to maintain fetuses outside of the womb for people that might want to shorten their duration of pregnancy.
I think there are some really legitimate ethical discussions to be had, and I'm not going to include that one as a legitimate ethical discussion. But there's been a huge surge in ethics papers related to this technology. We're up to 3 of them now, I believe. Never thought I'd be involved in 3 ethics papers, but the bottom line is a lot of it is misdirected. So they're talking about total ectogenesis. They're talking about significantly moving the limits of viability to earlier gestational ages. And in reality, for many reasons I don't have time to elaborate on, either one of our technologies apply to that. And so I think a lot of the ethical speculation is, like a lot of ethics, it's speculation on things that don't really matter.
James Dunn, Stanford. Is heparin used in your devices? And if not, how is it that things are not clotting?
So I presented our recent data. Our experiments previously, most of what I showed the animals were systemically anticoagulated. But the germinal matrix matures much earlier in a fetal lamb model. So we used heparin. We did not have in the fetal lamb model problems with bleeding. But of course, it's critical, in my view, for human application. So that's why we developed this Gnosis system of local anticoagulation. And so we had animals who survived for a week with no systemic heparinization and no bleeding or clotting. And I think that's going to be essential safety technology for clinical application.
So I would love to see Georgia's technology succeed and be clinically approved. I think it's a ways off from that still. We'd certainly love to adopt it in our system, but until then, we are heparin coated circuits and what we consider to be low dose, low target ACT of 180 to 200 heparinization. Do we need that? The difference in the system is that it's a very high flow, low volume system. And Emily's work with the AV pumpless ECMO that she was presented this morning was remarkable in that those circuits didn't clot over a 3-week period with no heparinization. And that's the oxygenator with the corners that you see thrombus formation in the corners of the oxygenator and maintain a central pathway of blood flow. So we'll have to test this in terms of how much heparin is needed. I disagree that heparin is the primary culprit in IVH in premature infants. It's usually related to their extreme instability, ventilatory changes, sepsis, all of those things. There's actually evidence that low-dose heparin can be preventive for IVH in extreme prematurity because it prevents microthrombus formation that is the nidus for hemorrhage in the germinal matrix, et cetera. So I think that point is controversial. I don't think the ECMO literature on ECMO application to premature infants is applicable because in general those infants are in respiratory failure, very sick, et cetera. So I think we need to rethink that a little bit, and I don't think we'll really know what the risk of IVH in the system is until we apply it clinically. Again, in the appropriate animal model, we have seen no evidence of intraventricular hemorrhage at any point in our experimentation.
But I would just add as a counterpoint, while it's true that there's data that critical illness, fluid shifts, ventilation influence IVH, those things are true in less premature infants and they don't have IVH. So I don't think it's accurate to say that extremely premature infants don't have a much higher baseline risk of IVH, which in my mind would be potentiated by any degree of systemic anticoagulation.
One comment, I mean, the issue of IVH, clearly autoregulation in their cardiac system, that's why it's so interesting to see the cardiac data. I don't think it's ever really been truly, even in terms of low-dose heparin, really examined. It's a hard thing to do in terms of, because there's so much heparin, you give a little push through the IV, that's an extra dose of heparin. So being able to account for that is really difficult. So I think really both those points are important in terms of we don't really know it yet.
It's interesting that the FDA hasn't raised that concern. I mean, I fully expected that to be a major concern on the FDA's part, but they haven't objected to the concept of having systemic heparinization at low levels in the fetus.
Thank you. I think in the interest of time, this will have to conclude our session. I want to thank again our 3 speakers for really amazing talks. And there's going to be a 15-minute break. And then I want to remind everyone that the very last session of this this annual meeting is back in the main conference room there where the scientific awards will be presented. So thanks very much for your time.